Welcome to Dental Unscripted. Where Mike Dinzio and Paula Quinn break down the practice ownership journey, one episode at a time. Starting up, buying, and running a successful dental practice.
What's going on, guys? Welcome back to another episode of Dental Unscripted. My name's Michael Dinzio, and I got my co-star Paula Quinn on the show. Hey, what's up, Paula?
Hey, not much. How's it going?
We're doing another one of these things.
Yeah,
so I know. It's been a minute, so hopefully you guys are still following us. Try to put out as much content as we can, but it's kind of the busy season, and we're doing the best we can. But today we got a really good episode because it's just Paula and I rapping today about hygiene and all things kind of how to grow your practice. And so we're just going to talk a lot about like how to get hygiene departments to produce more, and who better to have on the topic is Miss Paula Quinn. So we're just going to kind of get into it. But before we do, a little housekeeping. If you haven't heard it, if you're watching this on Startup Unscripted, get over to our other channel called Dental Unscripted. That goes for the same as those of you watching on Acquisition Unscripted. We're just merging all to Dental Unscripted. And this is going to be the place for all of our podcasts moving forward. And the topics are going to be about startups, about acquisitions, and also about practice management. So today's kind of a practice management topic of how to grow a practice and get things going. So let's just kind of get into it.
Do I get to just be the guest? I just get to sit here and be the guest?
You can be the guest. Do you have any housekeeping to add to that?
No, I'm the guest.
Yes, you are the guest. We were thinking today about, topics on how to just grow practices, and a hot topic is hygiene. And like in a world where hygienists are just so expensive, dollar wise, and pretty big range. Paula, where do you think the range is on pay these days for hygienists?
Statewide or just kind of
countrywide?
Countrywide.
I mean, it's all over the place.
Why'd I say statewide?
Yeah, countrywide. Yeah,
countrywide. I mean, I would say it can be as low as 40, but that's pretty unusual, especially here in the West. But I would say that there are probably some southern states that it could be lower. But I would say average, we're looking at probably 47 to 75.
Yeah,
here in the Pacific Northwest and some parts of California were up in the mid 70s.
Yeah. So like, in that kind of mindset, and also not only pay, but also like, I know it's probably not as bad, but do you remember post COVID when you couldn't literally find a hygienist anywhere?
Yes.
Just because you're talking to hygiene departments and practice owners all day, I feel like it's less of a problem, but it's still a problem.
Yeah.
How would you kind of frame up like the void that they've kind of left us? I can say you guys, because you're a hygienist, the void that you guys have left us, has it rebounded? Is it worse in some areas in the country than others?
Yeah, I think that it's worse. It kind of seems like, in my opinion, what I've heard, it's like the higher pay regions are the hardest ones to find. Those of us, for instance, Arizona, that didn't change a lot. I think it's still fairly easy to find. It's almost like the higher they got paid, the more, and maybe they did that because they weren't willing to work unless they got a lot of money. I don't know. But that's kind of the trend, is the higher they're paid, the less you seem to be able to find them. And then I think it definitely is area specific. It's just like any other employees, though. some areas are just harder to find employees in general, if you're in a remoter area versus other areas. But, I don't know. But yes, the answer is I do think that it's rebounded a little bit. I definitely see. I mean, we had dentists practically in tears, but I also will say a lot of dentists have become accustomed to doing their own hygiene right now. I mean, so I think there's also just less complaining because it's almost like they found a plan B and kind of just said, I just got to do this. And we won't get into it on this, but, even here, in the state of Arizona, passed a law where assistants, can take a certain amount of hours and do some scaling. So that's kind of what the hygiene
profession
has pushed to happen, demanding high
pay. Let's talk about that. I mean, the whole point of this episode is exactly what you're kind of throwing out there, that dentists have had to get really creative to fill this void. And we tell our clients all the time, if you can't get a hygienist, then you're stuck in the chair doing a $200, $300 PPO kind of procedure, and instead of doing $1,500 procedures. And so that's just never going to really pencil the way you want it to. And so, yeah, of course you have to do what you got to do to keep your business going. And we saw a lot of that in COVID with the doctors doing that. But now that some hygienists have come back, which is a good thing, they've come back. Let's kind of get into okay, so we can't really find a hygienist. And so when we do find one, we pay them a lot more, like you said. So the supply and demand is off. And if the demand's really high and the supply is really low, then prices are going to go up, just like they have in Seattle. So if prices have gone up, the only way to combat that is to produce more, to justify the ROI, right?
Fee for service.
Unless they're fee for service. And so that's the big topic for today, is how to get more out of your hygiene department, knowing that you're paying in some cases $70 an hour or more. And it used to be 3 times their wage, right? Is that what you used to say?
Yeah, that was the bare minimum 3 times the wage. Yeah,
bare minimum. So would we be lucky to get 3 times today with $75 an hour?
Well, with well-trained hygienists and motivated hygienists, you should get 3 times your wage still.
Still. Okay.
There's so there's so many other things, which I guess, we can get into in a minute, but there's so many other things that hygienists can do and bring to the table besides just the act of scaling, Yeah. That's one piece to the puzzle.
Well, let's get into it. So when you think about hygiene and trying to get the most out of those patients, what do you think the top things are? Where do we even start this conversation about getting more dollars per patient in that chair, in the hygiene chair? Where does your head go?
I mean, I would say first just diagnosing right. I think with a good perio program and a good understanding and a refresher every once in a while, sometimes just doing your local, what you have to do for your CEs isn't enough. It's really making sure that you're diagnosing correctly the first time. There's always so much opportunity, and I just see it over and over again, not happening.
Yeah. I mean, when you say diagnosing, you're talking to a layman here. I'm sure the dentists know a lot more about it, but what are you seeing that when you say that, what are you seeing in the hygienist today? Not diagnosing, what does that mean? Yeah.
Well, I wouldn't say it just today. I think it's, historically, I always, whenever I'm coaching hygienists, I think it's a very natural instinct when you're a caregiver to sort of want to minimize issues, not shame the patient. and sort of, usually I feel like usually you go into certain fields, whether it's, you ex-banker, hygiene, and a lot of the behavior styles are the same with hygienists, and they're a little bit more reserved. Not all. There's a lot of, different personality types out there, but they don't want to hurt people's feelings. They're caregivers because they want to give and coddle and take care of. And so when you have that, it's hard to have the person that's okay with a little bit of, I wouldn't call it confrontation, but having those hard, tough conversations. Do you know what I mean? And so I just find that they like to gently plant seeds, or they like to avoid, or if a patient's already been through something or even complained about another office doing something, they'll retreat and like not even touch that, so I feel like those can be challenging situations, and the general personality of the hygienist doesn't go with the general, what kind of the job. It's almost like up front when you got to collect the money, it's like a little bit harder, and that's not usually. So, I mean, you want me to explain what I mean by diagnosing correctly is, I would say most of the hygienists I talk to don't even know what 4346 is, or that there's a gingivitis therapy code out there, or they've heard of it and they tell me, oh, insurance doesn't pay for that. Or we try.
Well, why would they even be talking insurance? That's what's always fascinating to me.
You really want to go down that rabbit hole?
I mean, maybe you've got doctors on the other end of this thinking, it is part of the conversation that a lot of offices, by the leadership of the dentist, they allow their team to really have the insurance company dictate what they tell the patient.
Well,
I know it's like I'm opening up a can of worms, but
no, it's okay. I have an answer.
I'm sure for those of you that aren't watching online, it is classic right now that Paula is talking to us. Hold up your right hand real quick, please.
Me?
No, your left hand now. Don't switch what's in your hand. What did you do? You just had a flosser. Yes, you did it. Yeah, she literally has a flosser in her hand.
I was flossing.
You couldn't be more cliche right now, but anyways, okay.
Fiddling with it.
Anyway, okay, yeah. So like, again, I don't know. I mean, we're talking about diagnosing correctly. That kind of to me means that they don't have the insurance company telling them what to diagnose.
Wait,
insurance. They shouldn't be diagnosing based on the insurance company's stuff.
Well, what I find happens is, this isn't meant to be bad, so sorry if your name's Mary Sue, whatever. Mary Sue up front will submit, and either yes, it can be they can use an alternative code. It can be what I want to say. Gosh, Stefani's going to be so disappointed if she's watching this right now. They can downgrade. Sorry. There's a lot of things that happen with, like, for instance, we'll just give the 4346 for example. There's 3 or 4 different scenarios that can happen with the 4346. So I imagine Mary Sue says, Paula, don't use that code again. It didn't get paid, and it just confused the patient, and or they just downgraded it anyways. We might as well submit a 1110, which is an adult pro fee. And then that's in the hygiene mind now. So, if you're not set up for success from front all the way to the back, then sometimes, submitting certain, especially different codes that we're not used to, can fail you. So whenever I'm going in, I'm really arming not just the hygienist, but the practice with how do we do this and how do we do it successfully. But I do agree with you, Michael. The coding is only to submit to insurance. What's really happening in the chair are a couple different things. And so we've got to talk I'll try not to get over educate here, but we've got to talk in the patient's language. And when a patient comes in and we code them a prophy, okay, so think about this. You come in with gingivitis, pretty bad, and I do a prophy and you leave and it's covered at 100%. And then I put you on 3 months, you're going to say, why? And I'm going to say, well, you know, you have gingivitis. And you're going to say, yeah, but my insurance covers every 6 months. I'll be back then. You don't get the gist of what just happened there. So I like to, call a spade, and make sure the patient fully understands whether it hurts in their pocketbook, whether it hurts by having to come back in 4 to 6 weeks for an additional now prophy. I want the patient to be educated in that.
Yeah.
You know, and if the insurance denies it or downgrades it, or there's a copay with it, well, I mean, you waited 2 years to come in, or you don't floss, or you're not, you know, it's really, you have to diagnose what you see. If we went to a medical doctor, they wouldn't diagnose something completely different because insurance wasn't going to pay. They would say, hey, Paula, you need to be treated for this. This is what it is. It doesn't matter. Now, the front office has to be armed with the knowledge so they can help explain that to a patient, because we never want to do something without patient's knowledge and understanding and agreeing to treatment, but it shouldn't change the diagnosis in the back. So long story short, what I see often is we are doing bloody prophies, we're giving away perio, we're giving away gingivitis, and we're coding a prophy. And so it's bogging down our chair, it's bogging down our time. The office now, who's already limping along because they're getting reimbursed crap for a prophy, is now getting reimbursed crap for a free gingivitis therapy. You know what I mean?
Yeah. What I'm thinking about here is, like, the doctors are always saying to us, well, the insurance company's the problem. They're not paying us enough money. Damn it, Paula, the hygienist, is costing me $75. I should just do my own hygiene. And what I just heard you say was that the front office kind of slapping the hygienist's hands. The doctor's not stepping in and saying, no, we're diagnosing what it is. Nancy Joe, or whatever you said, Mary Sue at the front, quit dictating back to us as clinicians. So in a lot of ways, it's a leadership issue by the doctor not stepping in and saying, hey, we got to
rewind that a little bit. It's not always Mary Jo or whatever's fault, because sometimes the hygienists just don't want to have those difficult conversations. So
that's another
so we can't blame. I'm saying sometimes when I hear those myths, I know that's coming from the front, because the hygienists have no idea if a claim got paid or not. Now, there's a whole nother problem where hygienists, you know, whether it's because, like I said, it's their personality, it's the difficult conversation, whether they're just not fully educated. And I know they're educated because they have hygiene degrees, but for instance, the 4346, you know, unless you just graduated in the last few years, isn't common knowledge. So it's understanding, number one, the code is out there. Number two, what constitutes using that. And number three, how do we explain that to our patients and even help our front office? Like, hey, it doesn't matter. This is what it is. This is what we're doing. So yes. And then it's a leadership. If the doctor, you know, sometimes what I've seen a lot of times is they don't even look at the gums. They just trust the hygienist, and they're trusting their team, you know, and they should. But at the end of the day, we can all look at a perio charting, and if there's no bleeding points, someone probably isn't marking it. And if there's 30% of the mouth or more, we can all look at it and say, okay, this is no longer a prophy.
You say, I hear you talk about statistics, and you know, I don't know the clinical part that like you do and all of that, but I do know numbers. And I think, and I do a lot of practice analyses with our buyers, and I see a lot of 15 to 20, not even, I see a lot of 10 to 15% perio in practices, and that's low. And you've taught me, and the industry says that 30% is probably perio above the age of what, 30 years old
50% of the population over the age 30
has perio,
periodontal,
or has perio happening. Like maybe not. Yeah.
You don't have kind of perio. You have perio or you don't have perio.
I see.
So gum disease can incorporate gingivitis, but periodontal disease is actually, it's affecting the bone and the surrounding structures, your periodontium. So that's whether you have it on one tooth or one area or entire mouth, you have periodontal disease. It's certain bacteria that cause it.
Well, before we pivot away from diagnosing, unless we just want to keep going here, but no. we do see a lot of 4910s maintenance versus full-blown scaling and root planing. And I hear you say a lot of times that people go into like this maintenance phase when they shouldn't be just sitting in maintenance the whole time.
Okay, yeah. So you can't get to a 4910 without having perio treatment. But what I say, what you heard me say is sometimes offices will have high perio percentages because whoever was there before or historically, they had this, and then the patient goes into a maintenance, a 4910, but there's no new perio coming through. So they'll have like a 30% perio because they have so many 4910s. But then when you look at the actual active periotherapy, 4341 or 4342, those will be super low because no one's still diagnosing. But then doc or everyone's like, oh, we've got a 30%, perio in our practice. It's like, if you figure if 50% over the age 30 have periodontal disease and you're getting 20 new patients a month, realistically, 10 of those should be put into active perio. At minimum, they have gingivitis. I know it. I've done this for lots and lots of years. And what hygienists, I don't know if they forget or they, again, are scared. When it's on your watch, okay, let me rewind to when I was a younger hygienist. It wasn't until someone gave me permission that people go back into active perio that I was the same way, because I thought I failed my patient. I did periotherapy. They came every 3 months. A year later, 2 years later, I was like, oh my goodness, this patient still has perio. What's going on? I felt like I can't tell them. They've been doing exactly what I said, and now they have active perio again. Somebody has to say, it's okay. It happens. It's not you. It is the mouth. It's the environment. It's the oral habits, and it's just part of nature. You've got pockets in there that never really heal. Those bacteria and the patient never stays on the exact 90 days on the clock. It's like saying you're a gym trainer and you come to me for your fitness and I put you on a program and nothing, you don't get the results you want. Well, the other however many days you're on your own, you're eating whatever, you're not, you know what I mean? I can't, just because I see you every 6 months, every 3 months, I'm not responsible for you or your mouth or what happened.
Okay. So on that, so you're saying someone, again, I don't want to cover things that our audience already knows, but if you go into a 4910, there's never a situation where they would need scaling and root planing again?
I would almost say there's always a situation they would need it again.
That's where I was going.
Yeah. So, I would say I would be shocked if you did periotherapy once in a lifetime on a patient.
Yeah. So that's the point, is you see these huge 4910 maintenances and you see very little SRPs, and your SRPs, the big dollars. Let's talk about dollars, guys. We're talking about how to get more out of your freaking hygiene chair. Those dollars are a lot bigger on the SRP than pro fees and maintenance, both bigger. And so, okay, so if we got a lot of maintenance and we've got a lot of pro fees and we got very little SRPs, there's two buckets that feed the SRP, the new patient, like you said, and some people that need to jump from maintenance back over. And I think it's really
look at
good
you.
that
You could just
I think
be a hygienist now.
I think it's really good that you were vulnerable there and said, hey, look, the first whatever 10, 15 years of being a hygienist, you needed that permission. And it sounds like you have to be that coach sometimes with these hygienists on giving them that same permission, because yeah, I think that's good.
And with that too, we talked about the 43, 46, there's other coding that comes with perio too, that, we don't have to get into it today, but there are other, even your exam code looks different, and doctors aren't using that exam code for perio that gets them more money. So there's a lot being missed, I feel, in that whole situation of diagnosing right the first time, not worrying about planting that seed, and then properly coding all of that stuff so you're getting more bang for your buck. You're doing the work. You're doing it. Get paid for it.
Yeah.
And it's not doing the patient any good to sugarcoat it. You have diabetes, you have some other disease, you have it. Medical doctors never do it. Oh, you got a little diabetes, or probably
you got stage one. You got stage 1 cancer. It's fine. Figure it out.
Yeah. We'll see you back in 6 months.
Yeah. Let's watch it.
Let's
see if it goes to stage 2. Let's just watch phase 1 cancer.
Yeah. So it's really just, clinically calling out what you see, try to put whenever I do the coaching program, this is what I say to every hygienist. I don't know if they listen to me or not. This is what I say. If it were free and it was your own mouth or your spouse's mouth or your parents' mouth, it was free, didn't have to worry about insurance, how would you treat them? What treatment would you do for them?
What would you say? What would you tell your partner? What would you tell your parent? Like, would you tell them that they have perio? Would you tell them that
you'd say, I'm going to do a periotherapy on you. You've got periodontal disease. We don't.
In fact, we talked about.
I'd probably get you back every month.
That's right.
Yeah. What were you going to say? We talked over.
Yeah, I said, in fact, we talked about someone that has perio, and it's a hard conversation. And
but not a bummer hygienist as a friend. That's totally different. They were in my chair. I wouldn't have a problem.
You wouldn't have a problem because you got the loops on. You're a doctor at that point.
Right.
Okay, what are some other things that you think? We're 30 minutes in and we had a diagnosing conversation. I think that's important, but I'm sure you have 15 other things that you could add. It's kind of how these episodes go. We get into it and next thing you know, we're out of time. But if you had to choose one other thing, what would it be that would, just one, that would drive more revenue into that chair that could offset this $70 wage that we're paying for a whole column, 8 hours? Like, what's another thing, a little nugget?
Well, I'm gonna name the two, but I'm not gonna talk about the second one. I just want to say, don't underestimate patient experience and creating value and that whole relationship. Just don't underestimate it. It's probably one of the biggest things. However, it's a slower moving needle because it's not direct money. It's kind of like just something that organically happens based on how you treat patients and how that whole experience looks. But for time's sake, when we're talking about ROIing, the hygiene department and getting more out of it and stuff, I would go to adjunctive services because that's a immediate direct reflection on what happens to the production for the day.
What's that mean? Adjunctive services?
Adjunctive, additional services.
Uh,
So
I'm from Ohio. You say adjunctive.
Well, I probably didn't even say it right. I'm from Indiana. Well, it's as simple as those. It's as simple as and as complicated. The simple is fluoride, sealants, irrigation, depending on the treatment you're doing. It could be incorporating lasers into your practice for gum tissue laser for hygiene, a diode laser, and as big and complicated as, clear liner therapy, night guards, and things like that. So it's always, we're educated and skilled to assist and discuss all of these things. And, if clear aligners aren't a big part of your practice, that might be a little scarier. And, of course, I always cover that in my program. And then there's direct, if you sign up with a clear aligner, there typically some training that comes from those particular companies. But, so that might need a little bit, but just adding, fluoride, just adding, if it's even adult tooth that's doesn't have any decay, no signs of issues, whipping out I can whip out a sealant in 2 minutes, as long as it takes to put some etch on, rinse it, and put a curing light on, sealants.
How come I always wondered, like, why are sealants so focused on in pediatric dentistry? We have a lot of pedo clients, but then
because they're not covered, Michael. They're not covered by insurance. That's why.
It's always surprising that a hygienist to date, my entire life, me personally, has never brought up a sealant as an adult. Not one time. And I haven't had too many cavities in my life. So it's kind of surprising that there's options that providers are not having that discussion. So that's your answer.
It's mostly, if I talk to an office, they'll say, well, adult sealants aren't covered by insurance. Now, if you break it down, again, getting all hygiene and technical, as a hygienist, we never want to be the decision maker in that, because if there is stain or some kind of bacteria down there, and they say, if you put a sealant over it, you could seal the cavity. And however, most sealants today have a fluoride releasing component to it that they've done studies where it actually can stop that growth and be good for the tooth. So I think, again, it's education, it's leadership, it's the doctor, it's the owner, the dentist, the doctor, doing some research, incorporating it into their practice, and, stating, hey, let's all be in tune and aware of this. I would say 99, if not 100% of hygienists are going to want the okay of the doctor before placing it, but we won't get into when I like the exams. But if you get in early enough,
please don't.
I won't. But if the doctor comes in early enough, we have time, especially on an adult, to do a couple sealants. Now, children and tongues and the suction, can be a little bit tricky doing by yourself or in a matter of a couple minutes. But an adult can typically keep their mouth open. They can even help you suction. You can whip out a sealant if you've got some extra time, especially on those adult prophies that are, pretty slam dunk. We usually don't need a full hour. And if the tray is ready, and that's the other reason why it doesn't happen. It's insurance doesn't cover it. They're afraid to do it unless they get the okay by the doctor. And the last thing is they're not set up for success. So if I got to go get a tray and etch and sealant, and I'm asking the assistant, I just lost my 5-minute opportunity.
But what a simple thing for a business owner.
Oh yeah, and they're like, I wish I had Stefani, but an adult sealant probably pays. I'm totally guessing, fee for service is probably $70.
But what I guess that's what I'm saying. That's what I'm saying is folks, if you're listening, in my opinion, a lot of this is leadership. And I think it always comes back to leadership. And the doctors don't want to have hard conversations with hygienists. And And you know,
they're smart.
Huh?
I said they're smart.
Yeah, well, but you're the business owner, and the business owners are telling me that damn Delta Dental for not doing all these things, but the truth is we're not talking to our patients about the things that they need. And the other thing that a setup, get 3 setups every day and just have it ready. Like, just
100%.
build that in. Like, what is that's easy. Just do that. And then it's, I guess the other thing is like, I'm wondering, do hygienists, if they sold a sealant, does that production go to them? If they sold ortho, does that go to them?
Usually if they start and scan, it not the full amount. I mean, I think you should definitely track. We create either there's a scan code, or there's or there's photo codes. There's codes you can use, or you could make up a initial conversation code. And so as a hygienist, you could put that code in, and then as the patient journey through the practice, if doc goes and enrolls that, then you would know that it started with a hygienist, and there could definitely be a piece. I mean, you wouldn't probably get all the credit because you're obviously, like, you're not doing half the work, but absolutely, I think especially when you scan a patient and you identify malocclusion, and then you're talking to the patient and the doctor comes up and you're like, here's your softball. Paula's interested 100%. There should be some sort of split there of what production counts toward the hygiene team and what.
Well, I guess I'm thinking, like, in normal business terms, right? Like, I forget dentistry. Just forget it for a minute. Okay. When you're in the business world, you pay, who gets paid the most in any company? It's people. And then who of all the people make the most? Salespeople. Why? Because it's hard to do that, and that skill set's difficult. So, like, to me, if I'm a dentist, I'm going to try to get, most dentists aren't great salespeople, quite frankly. If I have a hygienist, the best salespeople in dentistry are the hygienists. There's no question about it. If I'm a dentist, I'm trying to figure out how to compensate them for their efforts, and making that really easy, because compensation talks, money talks. And I know there's a lot of hygienists out there that, don't want to be a salesperson, but it's not sales if someone needs something and if it helps them and if it's better for that patient. And I'm just like sitting here disappointed that never once in my entire relationship with dentists has anybody talked to me about sealants, and I would have paid for it. And so is it sales? If you're just simply telling me that, hey, this is an option, and then I get to choose if I want to pay for it? I mean, that's not sales. Sales is like almost trying to push something that maybe someone doesn't want, or trying to convince them. That's sales. Really, this is just education. So if you're educating me that there's options out there and I get to say yes or no, no pressure, cool. But like, you guys, ladies, dentists, business owners, figure out a way to compensate your salespeople and give them credit where credit's due, because you probably were not going to sell that ortho case. You probably were not going to sell that sealant. So make it easy. Make the systems simple.
I also just think as, this is totally off the subject, but I'm going to go here anyways. I wish hygienists were paid on production. I wish that we were paid like associates, because I guarantee a lot more of us would be looking for those things like sealants, Invisalign, fluoride, lasers, or clear liners, any of that, because our wage would be banked on that.
Better.
And quite frankly, we're producers. We should be treated like producers, but somewhere along the line, we just got this astronomical wage, whether we're doing prophies all day long or we're a rock star, co-diagnosing with our dentist, doing wellness scans, and constantly looking at that stuff. And it creates oh, any hygienist out there is going to kill me who hears me. It creates a comfort, or I was going to say lazy, but I wouldn't call it lazy. I don't think any hygienists are lazy, but it's contentment. And it's kind of like, well, I get paid whether I do a pro fee, whether I do floor, it's all the same. So why, kill myself in that hour? But then you have the other end of the stick where these doctors are already paying us 50 to 75, and now they have to incentivize on top of it, because the only way to get us to talk about a sealant is to pay me extra for it, or I'm not going to do it. So it's kind of a shame the way the industry fell and the way we do this. And I've told you in the past, the way we paid our hygienist, they own the business, and there's something to be said for that, because I could get her on the show one day, and that I never met a more motivated hygienist in my life that made 150,000 because she knew what she needed to do to run her business. So, it's a fine line. We are healthcare providers. We 100% want to take care of our patients and do what's right for them. And we want to, walk with caution and not feel salesy, but it also is a business. And like you said, if it's something that I need, it's not selling. It's something I need. I don't understand why we're afraid to talk about it. It's almost supervised neglect when we don't talk to you about a sealant.
No, that's where I was going to go. I was going to go there and kind of end the program on that. And that is like in all the practices that you and I have coached over the last whatever years, I can't think of one client that was salesy and aggressive and did some.
It'll never happen.
Yeah. And so this word of sales is ridiculous to me, because I know what sales is. And what we're talking about here is supervised neglect. It's not sales telling me that there's a sealant option. That's not sales. It's an option.
You feel kind of cheated now. You're like, wait a minute. Real quick story I always tell when I'm teaching. It's like, it drives me crazy when I go and like drop my car off and they do some stuff to it and I get it back and they're like, filter, it's red. And I'm like, why didn't you call me and tell me? I would have changed the filter, And then you have the other people that are like, yeah, and they were trying to sell me a filter, So it's, I don't know. It's hard, but I don't think I'd ever met a dentist or a hygienist that I would ever constitute as too aggressive in the enrollment or sales category. And I think if they two-folded it, they would still be safe. And again,
there's lots of like Instagram videos of like dentists, like the funny like comedians making fun of dentists about pushing dentistry. I don't think there's ever been an Instagram video or comedian on a hygienist selling me on a sealant. Like, come on, what are we even talking about here? Yeah. So I just think it's really interesting. And that idea of running a hygiene department off a percentage, this isn't a new concept. You did it 20 years ago. I'm just kind of surprised why we haven't adopted a more sophisticated way of doing this. And I unfortunately, it's people have gotten complacent. And so at the end of the day, there's lots of things that we didn't even probably touch half of what you were prepared for today. But it's almost, there's room for a part two. But folks that are listening, it's not Delta Dental's fault. They definitely have a part of this. It's not. It sounds like
I wouldn't. I'd be careful there.
Well, but my point to that is we just uncovered 40 minutes of all the things that you could do to offset stupid Delta Dental's fees. And I could say that at least 80% of our clients today, even the ones that you coach, it takes so much effort to turn this mentality around just to get the whole ship. And if the doctors just really push this, in fact, Paula, if you could think of the clients that were totally on board with what you were telling the hygiene team, and the doctor went in and said, we're doing this now, did that hygiene team turn it around quick? And then the doctors are like, guys, Paula just left. She talked about a lot of crazy things like sealants. How do you feel about that? Do you get the same results?
Oop.
You're shaking your hand no. So again, leadership. Just believe in what you're doing and drive it, and guess what? The team will follow. So I guess with that, let's sign off on this bad boy. But
Yeah.
I appreciate your brain, Paula, and this topic, and maybe we do a part 2. Anything else to add before we shut this?
No, you better
down?
not get me started. I mean, I like that my brain is all over the place, but yeah, no, it's good. We'll maybe do a part 2 at some time. Nope, I think it was great.
All right, guys. Well, another episode of Dental Unscripted.
Thanks
Follow
for having
us.
me on. Thanks for having me on.
Yeah, thanks for having me on. Get out of here. All right, guys. Talk to you later. See
Okay.
ya.
All right. Bye.
Thanks for listening. Let us know how you like the show. Rate us on Apple and Spotify. Subscribe and follow for more. Thanks for listening. Let us know how you like the show. Rate us on Apple and Spotify. Subscribe and follow for more.